you. Thank you. I'm glad to be here. Come on. Okay, so I'm happy to talk to you today about caring for families with cancer risk. And you already got my introduction, so you know a little bit about me, but I teach in the College of Nursing. I teach graduate students, and I brought a few of them. Say hi. Those are the graduate students from the College of Nursing. So these are all students working on becoming nurse practitioners. And I worked as a nurse practitioner in women's health. So I've had the opportunity to diagnose patients with cancer, counsel patients who've been concerned about developing cancer. And that brings me to where I am now. So about you, you guys are, raise your hand if you're a Simmons Cancer Research Fellow. Yeah, that's what I thought. Okay, and you guys are working on what? I'm guessing that most of your research relates to either prevention, diagnosis, or treatment of cancer, ultimately, depending on you're looking at a certain enzyme or a certain gene. I just want to know by raise of hands. I'm going to ask each of these. So raise your hand if what you're working on could lead to prevention. Nobody here is in prevention. Raise your hand if what you're working on could lead to diagnosis. Okay, one. And raise your hand if what you're working on could lead to treatment. The rest of you. Okay, very, very good. So most of you are going to find the cure for cancer, and I am so very excited about that. But the current world situation is such that we don't have the cure yet, right? We've got very, very good treatment, but we don't have the cure at present. And so I appreciate all the work that's being done at the genetic and the molecular level. Some of you might be working with tissues and organs, or I could have put an animal up there for animal model. My research has more to do with people at risk for cancer and families with cancer. And that's what I'm going to talk to you about today. So cancer prevention, right? There's two categories of prevention: primary prevention and secondary prevention. And primary prevention relates to not getting it, right? So preventing cancer literally. And we can work towards this with things like lifestyle, medication, surgery, vaccinations, right? Did you know, how many of you all knew there was a vaccination for cancer? Raise your hand if you knew that. Some of you did. Okay, so we're talking about the human papillomavirus. Now, secondary prevention has to do with reducing mortality. Secondary prevention in any disease has to do with not having bad stuff happen once you have it, right? So secondary prevention for a diabetic patient, we want to not lead to an amputation, right? Once you have the disease, what can you prevent? So with cancer, screening and early detecting, the theory is that we can maybe prevent the bad stuff from happening, right? And who's responsible for that? There's a variety of healthcare providers, and since I'm talking primarily to a non-healthcare provider audience, I wanted to make sure you knew who some of these folks are, what roles they play. So, you know, MDs are medical doctors, they're MDs or DOs. Nurse practitioners are called NPs, physician assistants are PAs. There's a role called the genetic counselor. Has anyone heard of this? Raise your hand if you have. Okay, so some have not. These are people who do kind of 1 or 2 time consultations about genetic risks. There's also medical geneticists who are MD prepared, but then have gotten specialty in genetics. So let me ask you, who among these can be PCPs, or primary care providers? And my MPs cannot answer, so the rest of you can answer. Who can be a PCP? Go for the easy, go for the low-lying fruit. Doctors can, right? Who else can be PCPs? Nurse practitioners can, good guess. Who else can be PCPs? PAs can be, yes. They don't practice independently, they have to practice, but they can be a PCP. So typically your medical geneticist and your genetic counselors are kind of 1 time or 2 time or maybe a few times over a lifetime consultants. And that's going to be important for you to understand as I get a little bit into the problem and the research. All right, but anyone who's a PCP, it's important for them to understand how to screen for cancer and how to help assess risk for cancer. But one of the challenges is that a typical PCP visit is about 15 minutes. So in that amount of time, I'm supposed to complete a head-to-toe physical exam. I'm supposed to decide if your rash is bacterial or fungal. I'm supposed to figure out what immunizations you're due for. And I'm supposed to decide if you're at high risk for cancer or not. So as you can imagine, it can be a challenge. But if we find people at high risk for cancer, what do they need? 3 things. They need to understand what their risk is, right? Is this high, medium, or low? And we know from the research that people do a bad job of estimating their own risk. If you ask women, what do you think the chances are that you're going to get breast cancer in your lifetime? You can have a woman at 10% risk estimate 80% because her sister has it, right? So there's a lot of research about risk assessment, risk understanding in people, and they don't get it. So they need that. They need to have education about risk-reducing behaviors, so if they are at risk, they can decrease the chances. And they need to be offered appropriate screening. So, appropriate screening, right? That would be like mammography. So, is this statement true? I want you to go out on the line. I'm not going to tell you that you're wrong no matter what you say. So is this statement true? Does early detection save lives? Yes or no? Some say yes. Anyone want to offer a counter argument? Anyone suggest that maybe it does not? Okay, yeah, maybe a counter argument, okay? And you would not be inappropriate. There's literature that argues that case. And I'm going to share with you some of the concerns about that. So when we do something like some kind of screening intervention like mammography, it's always a balance, right? What are the risks? What are the benefits? What's the harm and what's the good? So any kind of test, you can have a problem with false positives. And this is the chance that someone who doesn't have cancer is going to have a positive test, and they're going to worry until they get a follow-up test, and then we'll find out if they really had cancer or not. About 10% of all women who go have mammography end up with a false positive. Only 5% of them who are called back have an ultimate cancer diagnosis. So that's a risk. False negatives, that's a dangerous one, right? We can offer false reassurance to a woman who actually has cancer. She maybe feels a lump and the mammogram was fine, so I'm not going to come back, right? That's a real risk of screening. Overdiagnosis, this is one of the more tragic potential harms of mammography, where we diagnose something as cancer that never would have become apparent in the woman's lifetime, that never would have caused harm. Something like a carcinoma in situ, right? Carcinoma in situ has 3 possible trajectories. It can progress to an invasive metastatic cancer. It can sit dormant for years and years and years and eventually become a problem, or it can regress and go away. And we don't know which of those a given carcinoma in situ is going to be. If we did, well, some of you guys need to find that out for us, because that would really help, okay? So they get diagnosed and then treated. And treatment can be surgery, treatment can be radiation, treatment can be chemo. Those are not harmless. There's a small theoretical risk of inducing cancer from radiation. This remains theoretical. It's slight if it's real. So benefits of mammography, right? If the idea is that if we find it early, we can treat it better, right? Treat it easier before it's bad. And the big one, if it's true, is decreased mortality. Does mammography lead to decreased mortality, right? So initially, when mammograms came out, there was a lot of joy over the decline in death rate from breast cancer. But people said, hey, wait a minute, we also got a whole lot better at treating cancer during those years. So we can't necessarily say that there's a 100% cause and effect right there. So it's a challenge, because when we compare screening detected cases and cases that are detected by clinically, we're susceptible to certain kind of biases in how we might evaluate that research. And I'm going to share with you a couple of things you have to be careful of when you're looking at the research related to screenings. One of those is lead time bias, okay? So you have a certain point in time where your disease starts, and we can't detect it for a long time. Eventually it'll become detectable clinically, and eventually maybe, but if a person's going to die, there's going to be a time of that, okay? So there's the potential when evaluating screening tests for what's called lead time bias. This idea that, oh, we detected it earlier and therefore our survival time is longer, right? Someone who was detected by a screening at age 45 but dies at 60 has a 15-year survival. Someone who is diagnosed clinically, right, we find a lump, only has a 10-year survival. But if nothing changes because of the screen detection, then we didn't save a life, right? So that's a potential bias we have to be aware of. Another bias is length bias. Length time bias is the premise that screenings are going to pick up slow-growing cancers preferentially. So a screened population will always have more cancers detected. But because longer-growing cancers are less lethal, they're more likely to pick up cancers that are long-growing, and therefore people have better outcomes because they're less lethal. So screened populations can appear to do better than populations where cancers are found clinically, because these cancers will be overrepresented in a non-screened population, and these cancers will be overrepresented in a screened population. Overdiagnosis bias. I was telling you before that screening can pick up non-cancers. So yeah, definitely if we pick up something that never would have turned into disease, then the screening looks great because you lived a long time. Self-selection bias has to do with the idea that when you're looking at whole populations, people who participate in screening are more likely to have a healthy lifestyle, and we can't make people pick a screening. So we need to be aware of these, and these are just kind of things to think about as you look at the literature related to screening. So I wanted to share a couple of articles with you about early detection. These aren't mine, but this one was published in the British Medical Journal, and they wanted to look at whether survival rate, well, what they wanted to look at was whether early detection really did increase survival rate. And they wanted to make sure that they accounted for the difference in treatment that was going on earlier in science and later, right? In the 2006 to 2012 era, we had better cancer treatments. And what they found is that if we detect a tumor at an earlier stage, this blue line is an early stage, great survival, right? If we detect it later, less good survival. So the later the stage, the poorer the survival over time. But that's still true. Even with our better treatments, if we catch it earlier, survival is still better. So that supports the idea that early detection is still helpful, because early detection can find tumors at smaller points. This systematic literature review was conducted by the scientists looking to make the American Cancer Screening Guidelines, and they took into account all RCTs that have been done up to the point they published. And overall, even with accounting for biases and controlling for them, the best estimate is that for women of all ages at average cancer risk, the reduction in breast mortality is about 20%. So we'll go ahead and go with it for now, right? That early detection does save lives. Currently, it is a recommendation by all the major recommending bodies that women get mammography. And one thing that's good for me in my research, because my research has to do with finding out who to trigger, who to send for these screenings, especially high-risk women, is that in a high prevalence population, screening tests are always going to perform better. Just mathematically, there's less false positives, and there's a better positive predictor value. So these are the guidelines as they stand. They do vary based on the level of risk. They vary based on start date, but mammography is currently recommended for all women at all risk levels. In addition, now I want you to be honest with me and raise your hand if you didn't know this, but it's recommended that women who have more than 20% lifetime risk receive annual breast MRI. Who is that new news for? It's not for my NPs, but it's new news for a few people in the room, right? It's not new news for you. Okay. So this is a mammography if you haven't ever seen one or had one. This is a breast MRI. Breast MRI is a lot more expensive, right? But it's a lot more sensitive in picking up cancer. And so for the higher risk population, it's a helpful thing. But here's the challenge is how do you know? How do you know who's at 20% lifetime risk, right? I can't just walk around and look at your foreheads and go, you and you and you, right? So this is how you figure it out. There are a variety of statistical models called risk calculators that can help you figure out if a person is at increased or actually give you a percent estimate of the risk that they'll get cancer in the next 5 years, in the next 10 years, in the next lifetime. And all of the guideline organizations, the guideline offering organizations recommend that we use models that are largely dependent on family history. These are a few of the names of the models: the BRCA Pro, the Klaus, the Tyrer-Cuzick. Unfortunately, the most prevalent model that's used in primary care practice is the Gale model. It's very easy, it's online, you click a couple boxes and you have your number. But that number cannot be used to determine who should qualify for breast MRI. So we need to learn how to use these in primary care if we're going to use them there, or refer to people who do. I'm going to show you a little bit how to use the Tyrer-Cuzick model so you can just get a sense of what these models look like. But it's going to be a whirlwind overview. So if you really want to use the model and know how to click the boxes, I refer you to an article we published in October. Although I'll tell you that the model got updated since it was published. So that's how quick things are turning around. We did a webinar just last week actually on how to use the updated model. So if you want to use it, you can ask me or you can go to these sources. But basically you download software and then you're brought to this screen and you enter data. And it has the ability to archive your patients for you. As you're looking at the different information that's entered, what I want you to be thinking is these are all the risk factors that this model accounts for, right? Oh, and I forgot to mention that I meant to. Anyway, I'll come back. So I want you to be thinking about all the personal factors that this model accounts for. For example, age, height, weight, menarche, parity, premenopausal status, postmenopausal status, whether a person's had ovarian cancer themselves. If a person is menopausal, have they taken hormone replacement therapy, and if so, how long? This is the new piece added to this latest version, which is mammographic density, because that is a risk factor for breast cancer. People of Ashkenazi Jewish inheritance are also at higher risk, and so you can mark a box if they have that ancestry. Then you'll work through these boxes to build a pedigree. And as you check boxes, the pedigree builds on the right. And you're going to enter data about all first, second, and some third degree relatives. There is a little bit of, it does matter a little which box you check first and what kind of information you enter. So I refer you back to the article if you decide to use the model. But in the end, you can calculate a risk for this person. You check the box for competing mortality, which adds in the chances that this person might die of other causes. And then you calculate the risk, and this is what you get. So if this individual is 49 years right now, and they don't have breast cancer currently, so there's 0% chance that they do, because they don't, what are the chances that by age 54 they'll have breast cancer? And in comparison, what about a member of the average population with average risk factors? What are the chances that they will have breast cancer by 54 or 59 or 64? So you can see the calculated person's lifetime risk and the population lifetime risk. So that's how we find out who's 20% or more lifetime risk for breast cancer. So the challenge is, when does this get done? When does this calculation get made? Can happen in a couple places. One is a person's primary care provider can run a calculation for them. Another one is that in families that have had cancer, a lot of times a woman who, say, has breast cancer will be concerned if the rest of the family has an appearance that there might be a hereditary component. If, say, the tumor was triple negative for receptors, HER2/neu, estrogen, progesterone, right? Those are more likely to be hereditary cancers. This person who's had cancer, once they make it through their surgery, once they make it through their treatment, they might go counsel with a genetic counselor to find out about their risk. So one of the challenges in looking at these cancer families is that there's not just one cancer syndrome, right? So tell me what gene mutations you've heard of, not my MP students again. But what genes have you heard that are associated with breast cancer? Yeah. BRCA. What else? Anyone else heard of BRCA? Lots of BRCA. Okay. So there are a variety of hereditary cancer syndromes. BRCA gene mutations are one, but we can have mutations in the TP53 gene that you guys have probably heard of, causing Li-Fraumeni syndrome. That confers a 90% chance of breast cancer by age 60. That's huge. The P10 gene mutations here can cause Cowden syndrome, right? 20 to 50% lifetime risk. STK11, Peutz-Jeghers, CDH1, primarily associated with gastric cancer. That's the name of the syndrome, but also associated with breast cancer. So it can be a challenge to decide what testing to do anymore. We're getting panels, which has been very, very helpful. But we do all these tests. Maybe we run a panel on everything, and then what do we know? What do we find out? Okay? There's possibilities, right? If someone else in your family has a mutation in BRCA, you can get a test and you can be positive or negative. But if you're the first person tested in your family and your family looks like it's a cancer family, you can be positive. But if you're not positive, we don't call you negative. And the reason we don't call you negative is because the family still looks like a cancer family. There might be other genes, there might be other factors, and so we use the term uninformative negative. Another possible test outcome is a variant of uncertain significance, which is even harder to explain to your patient. So, we have a situation where somebody goes to a genetic counselor, they get a test, but no positive result, right? We have a family that looks like a cancer family. It looks like the problem might be somewhat familial. What do we do? Well, the genetic counselor might run a risk calculator, and if they do, then they would share with their patient, their consultant or proband, they would share the likelihood that a family member might be at risk. But because of privacy rules, we don't typically see a genetic counselor going and telling all the different family members about their risk, right? And we know that there's challenges with this communication line, right? So information doesn't always get through. The information that gets through is sometimes incomplete. This person right here also has a chance of learning about their risk if their primary care provider does a thorough risk assessment, like we suggested in our article, but sometimes that doesn't get done either. So sometimes this person can be left a little bit in the dark. And if you look at family communication theory, there's reasons for that, right? Communication privacy management is one family communication theory. And what it states is that every family member has to weigh their value on privacy versus disclosure. Maybe you don't want to tell, maybe you're okay telling some people but not others. And all families have kind of rules about communication, right? There's linkage rules, which have to do with who can know. Permeability rules, like how much can they, I'll tell them a little but not everything. Ownership rules, who does this information belong to? A lot of times in cancer families, we see that the women are in charge of the information. It's very interesting, especially when it comes to breast cancer, but really kind of any kind of health issue, the women share it. And so a lot of times men are left in the dark in their families. Families have all different patterns of communication, right? Families have different boundaries. Some have very permeable borders and some have very solid borders. Some families are more cohesive and sometimes less. And in every family, there's patterns and rules about communication, and there's also complex relationships where there's like all these little interpersonal dynamics, you know. If someone's estranged, how do we let them know about the risk? So now you have some background. I'll tell you a little bit about a study we did that was published last year. And what we looked at was family members of women who had had genetic counseling and testing with uninformative negative BRCA mutations. BRCA test results, okay. So now you know all those words, right? So one thing that's cool about the study is that the women, the sisters or mothers all received standardized genetic counseling. Every genetic counselor shared a summary letter with their consultee that said, here's the risk of your family members, and you should share this information with them. So they all received the same instruction. In addition, because previous patients had wanted it, they all received information pamphlets to help them be able to share information about cancer and heredity, all kinds of things that would be helpful, right? So the people that we looked at were 85 women between the ages of 40 and 74. Every one of these women had either a mother or a sister who had had breast cancer, had had genetic counseling, had been tested for BRCA1 and 2 with uninformative results. And what we wanted to find out in this study was, one, how at risk were they, and were they screening like they should? Number two, how much information was being shared, trickled down to them from their sisters and mothers? How much were the family members talking and communicating with their primary care providers? And did this information sharing by a family member influence how well they understood their risk? So I'll break down the results for you. We collected data. It was a cross-sectional descriptive study, and we collected data by survey and telephone interview. So what did we find out about their risk and about how they were screening? So remember, these are 85 women who all had a sister and mother with breast cancer, and it all looked familial enough that the sister or mother was sent for genetic testing, but no positive result. Most off, they were not at high risk, right? So 89% had less than a 20% lifetime risk. So we had to run a risk calculator for every one of those. That was a big deal. And most of them were getting recommendations from their PCP to get annual mammograms, and most of them had had a mammogram in the last 1 to 2 years. So these guys were doing just fine, right? A couple of them had had a breast MRI, but it was totally appropriate. They were following up on some abnormal finding. So we found, though, that over 10%, 10.6% of them had more than 20% lifetime risk. And all of them were receiving mammography recommendations, and most of them were getting mammograms, but 0 of them had had a recommendation from their primary care provider for MRI, and 0 of them had had an MRI. So we're not doing so well screening our high-risk women with breast MRI. All right, what else did we find out? We looked at information sharing, and we were curious how much the person who had counseling shared with the family member. And so we said, hey, rate on a scale of 0 to 5, how much information did your sister or your mom share with you about what she learned in genetic counseling? So this was kind of shocking because 18% said, what? She had genetic counseling? She had genetic, what? And it was really weird because the person who had genetic counseling had referred their sisters to the test. You think they would have mentioned, right? But they didn't. So, so 18% did not. Less than 20% were high sharers in this 4 to 5 category, right? So the next thing we wanted to know was how many of these family members even heard about this summary letter, because we thought, oh, this is a great idea, right? We'll give them something in writing. They can share that. Okay, well, 12 of them knew there was a letter, 12 out of 85. That doesn't mean that this person didn't use the information in the letter as they shared information, but family members were clueless that there was a letter and that it was even less about a pamphlet. So then we want to know, okay, so this person without cancer, right, this woman, she's not getting a lot of information from her sister who went to genetic counseling about her risk. Is she getting information from her primary care provider? And one thing that we thought might be really helpful is if she mentioned to her primary care provider that, hey, my sister had genetic testing, because that might send off like the little red flag, like, oh, a genetic counselor thought this family was worth investigating. Maybe they're at higher risk. So most of the women did a great job telling their doctor, nurse practitioner, PA that there was a family history. Probably mostly that happens because we always get asked about our family history. But not very many shared information about their family member having had counseling and testing. All right, so this was kind of the most interesting result. Well, I think they're all interesting, of course, but this is really cool. So we set up a structural equation model, which, have any of you guys used structural equation modeling? You have? Okay, that's it. All right, so the whirlwind view is that circles are latent variables, meaning that we're assuming that there's a true construct out there that is a real calculated lifetime risk of breast cancer. No model in particular can be perfect. There's always going to be error. But you can use more than one indicator variables to measure your construct. And you can partition out the error, which is a beautiful thing in structural equation modeling. So we calculated their lifetime risk for breast cancer with 2 calculators. We assessed what they thought about their lifetime risk by having them give a number rating, a categorical, and also quantifying it, giving a percent. And then what we wanted to look at was how well did this match this, right? If this line is 1, that would be a perfect correlation. And so we treated this line as accuracy of risk perception, right? And so in the model, we wanted to know how much the amount of information shared influenced accuracy of risk perception. Was it a moderator? In other words, if women shared more information about genetic counseling with their relatives, did the relatives understand their risk better? Because that's our theory, right? Go share this information with your relatives. It will help them. Does it really help them? That's what we were testing with this model. So in order to check the moderating effect, we had to break how much was shared into 2 categories. So we split right here with these people sharing a great deal being high sharers and these people who shared nothing up to level 3 being low sharers. And this is what we found out. So people who shared a low amount of information had the strength of this association was 0.3. Remember, 1 would be perfect correlation. So it's 0.3, and that was statistically significant. What was really interesting is that if there was a high amount of sharing, it doubled the accuracy of risk perception, which is pretty incredible. But the really sad thing is that how many people are high sharers in the families? It was 17%. So why does it matter? Why does it help you to understand your risk? Because you can take prevention measures like participating in screening, like eating healthy, like following the recommendations of your primary care provider if you understand your risk level. So what have we learned and where do we go next? So we learned that the communication here is spotty. We learned that the communication here is kind of spotty. In fact, we had one family who, the woman here was, and this is not part of the study, this is a side family, right? The woman here was at 28% lifetime risk, right? And the genetic counselor had told her sister, hey, your sister should probably get annual MRI. And so this woman without cancer even went to her PCP and said, hey, my family member saw a genetic counselor, had testing. They told me I should get an MRI. OBGYN says, oh, you don't need that. You don't need that, right? So what do we need, right? It's hard. We need perhaps better interdisciplinary communication. We need perhaps better ability to assess risk at this level, but keep in mind that we have very limited time frames to do that. So what are we doing next? What are we working on now? We're currently doing a systematic literature review. We're going to be evaluating all the different ways that have been tried to share information about risk within families. And then we're going to go ahead and take a look at trying to implement some of those ways. The answer may ultimately be an informatics answer, right? How do we share information? How do we share data across families? But we're working on it. The area of research that I participate in is called precision medicine, meaning that we look for optimal ways of treating people who are stratified into groups based on their genetic and molecular makeup, right? And it can be hard. It can be hard when the people who are treating the general population have to be aware of so many different potential risks and so many different possible disease. But we'll get better. So while I am excited for the day that you guys find the cure for cancer, but when you do, we're still going to need to get people to take the pill and tell the information to their families. So we're going to need to work on this work. In fact, as a side note, patients with chronic conditions, their compliance rate for medication adherence is anywhere between 25 and 50%. So we prescribe, here's your prescription, go fill it. We measure how many pills they take, about half, maybe 25%. So you guys find the cure and we'll get them to do it, right? So now you've learned a little bit about nursing science. Some nurses practice at the bench like you all do in your fellowships that you're working on. I don't. This is my bench. This is where I practice and study. But yeah, thank you. Any questions? Yeah. Oh.
I'm just curious, when you divided two groups of low sharers
Yeah.
and high sharers, right?
Yeah, that's a great
Did
question.
you look at all at what kind of was...
We looked at...
Low sharers actually shared important information versus high sharers sharing a lot of not...
So we did not get tapes of any of the conversations. There has been other research. There was a researcher named Vos who has an article, I love it, it's called The Whisper Game of Genetic Counseling or something. They actually recorded what the genetic counselors told the probands, what the probands told the family members, and what the family members think they were told, and the drop-off is terrible. So no, we only quantified how much, that was it. So we were kind of astounded that we got significant results, that simply families that talk more about these things, they understood more. So yeah, good question. Yeah?
Did you look at family dynamics for high sharers versus low sharers?
No, that could be next. I don't even know if we have anything that really approximates that. What's that?
Like how old they were, what ages they were, what position in the family they were.
Yeah, no, we didn't pull a lot of family theory into it. So we know family theory affects it, but we didn't get those endpoints. Although one of my grad students who walked in here is doing a secondary analysis on this data set, and we did look at how much sharing affects knowledge about breast cancer genetics. We actually gave them, was it 22 questions? 27 questions? So you should share those results because you found them.
So what we found is that women, so it was highly significant in families where a higher amount of information was shared. We used the same.
Cut point.
No, we didn't actually cut it off.
No, we
just
didn't.
found a correlation.
That's right.
And we found that in families that of a higher shared more definitely knew more about cancer.
Even things like what autosomal dominant inheritance looks like, what kind of risk, like they just knew more. So it can't be, we can't consider it causation, of course, right? But there is a connection there. So family dynamics are important. Good question. Other questions? Well, you guys, thanks for your attention. Appreciate it. Okay, thank you.